Hi, this is Bruno Trindade, and we're here live from Rio during the Brascrs meeting in 2024. And I have a very special team here right next to me. I have Bruna Ventura from Recife. She'll be joining me with these two big guys, two great guests. I'm so excited to have you guys in Brazil. It's a true honor to host you here, and I hope you are having a good time in Brazil. Dr. Warren here and Dr. Cathleen MCCabe, thank you so much for stopping by and having this chat with us.
Thank you for having us.
Yeah, so happy to be here.
Yeah, it's amazing. I think this meeting is turning as a very nice place with a bunch of experts from around the world. And again, the idea here is for us to interact a little bit deeper and to get yourselves to your thoughts on different aspects of ophthalmology, right, Bruna?
Yes.
And we were talking a bit before we started recording this on the way both of you manage presbyopia or pseudophakic presbyopia, and I understood that you have a very different approach. Maybe if you could start, Warren, to talk us about how do you manage presbyopia in your cataract surgery patients?
To mini monovision. And we have kind of an unusual practice. We see a lot of people for other physicians, and we would see a lot of unhappy multifocal patients. And mini monovision kind of became the standard for us. And mini monovision has a lot of advantages if it's done correctly, and some disadvantages. The main advantage is there's no dysphotopsia, there's no reduction of contrast, but the disadvantage is you don't get paid extra, and then it takes as much work as a multifocal lens. You have to hit the distance eye exactly. If there's astigmatism, you have to correct that. And then the near eye is a little bit of an art form. You know, it could be like -3/4, -1, -1 1/4. It really depends on the patient. I've had cataract surgery myself, and I have mini monovision, plano in one eye, -3/4 in the other, and I'm very, very happy. There's most patients, if you do say,
Sorry,
go ahead.
what kind of lens did you use in your own eye?
I have unusual corneas, so we did the light adjustable lens because the calculations were a little bit problematic. So
Well, coming from you.
well, just
Yeah, I know.
yeah. Well, the story is I have a low Gould strand ratio, like you see with myopic LASIK, but I've never had refractive surgery, and I have a lot of astigmatism, very steep Ks, and the posterior cornea is just this side of ectasia, which is, you know, where do you even start at something like that? I actually did the calculation. We tried, and we were off just a little bit. So it's an ideal application for a light adjustable lens for the unusual cornea. So to answer your question, for the distance eye, I'm hard plano, and then for the near eye, I'm -3/4. Corrected all the astigmatism, and it's worked very nicely. In general, with mini monovision, you may not get that really nice close vision. But for the majority of patients, wherever they look, everything's in focus. If they want to read the small letters on the medicine bottle, they might put on some readers from the drugstore. But for the most part, they're very, very happy, and we don't see the same kind of complaints that people would frequently have, especially if they have an unusual cornea. If they have coma or anything like that, it can be problematic. So that's kind of where we've drifted, and it's worked well for us.
And you were saying that that's the sole correction of presbyopia that you offer at the moment, right? It's just mini monovision for everyone,
And our premium lens is the toric.
right? That-
Question, is that based on like a monofocal base variant only or a monofocal plus lens? What's your go-to? Because we don't have adjustable lenses in Brazil. Okay, so
Right.
taking that out
It's
of
just a
Yeah.
monofocal lens.
monofocal, not monofocal plus.
Right. And so one other concept with mini monovision is the concept of cortical summation. So if you have one eye that's hard plano and the other eye's -3/4, maybe -1, at distance, they see well. If they cover their near eye, they see well. They uncover their near eye, they actually see better, which is interesting. For for near, if you cover your distance eye, you see well. If you add your distance eye, you actually see better, which is kind of interesting. A little bit of physiology you can use on your behalf. So for the most part, I can't recall anybody being unhappy with mini monovision, saying, I never should have had that done. I wish I would have had that special $4,000 lens. No, and it's worked well for us, and it avoids problems as I see it.
You advise the patients not to be like comparing the eyes. You explain to them one eye will prioritize far, another eye will prioritize near, or you don't take the chair time to explain it.
Just the opposite. I say, okay, when they're all done on their last visit, cover your near eye, see distance, looks good. Now uncover your near eye, it's better. That's cortical summation. And it's a lovely thing to show people.
Yeah.
And I say what this means is not only is the concept working well for you, but your brain is participating in it. Remember, we don't see with our eyes, we see with our brains.
Yeah.
And the brain assembles the image. And if you give the brain exactly the right information, you can use it to your benefit.
Mm-hmm.
But again, it's as much work as a multifocal, and we don't get extra reimbursement. So that may in part be some of the reason why it's not as fun. But other practices have spent a lot of time with that. Look at Graham Barrett. That's what he did pretty much his entire career. Although he added spherical aberration of the lens as a fixed value to help with that. And I think there's a company right now that's making that special lens for Graham Barrett. So anyhow, it's just our preference. It's worked well for us, and I'm living proof that it actually does work. Sure.
So is there anything about your experience now that you've had cataract surgery with mini monovision, which you've been walking your patients through for many, many years?
Sure, yeah.
Was there anything that surprised you about your own experience that was different, or maybe you can explain it better?
Yeah, that's a very insightful question.
Yeah.
What surprised me is how well it worked. I told my patients, it works, you're going to like this, and the feedback I would get was, yes, it works. Damn. It works better than I thought.
Wonderful,
And so
wonderful.
a few weeks after my experience, my wife was so impressed she had it done for herself. So
That's convincing. That's very convincing.
And how's she doing?
she's doing great.
Better than you?
She's doing as well as me.
And Bruno, one thing is, it's not just quality of vision that you perceive, it's good vision, but you're a surgeon, you're a pilot, so you really need good vision. And you're getting it through that strategy, right?
Well, the FAA says I have to have vision at a certain level near intermediate distance, and I can do all of this now without glasses.
Uncorrected.
So in fact, I've worn glasses since I was 8 years old. This is a little different. It took me a little while to get used to not wearing glasses, so I'm absolutely thrilled.
Do you want to share what your refraction was ahead of time to give people perspective?
I'm an axial hyperope with 2 diopters of astigmatism.
Well,
so-
how much
and
hyperopia did you have refractively?
22 something on the axial length. Yeah. But as you know, us hyperopes are so grateful.
Yes. They're the best patients.
Kathy, and you have a different strategy on treating presbyopia, right? What can you share with us?
I do, although we do use mini monovision as a strategy, but I tend not to do monovision in patients who have never experienced it before. And I know that you do that very successfully, but I've had good success with multifocal lenses and with EDOF lenses as well. And so my first concern when I look at a patient who wants more independence is just what's the health of the eye? And what's the health of the ocular surface? And because those things are so critical when you're really, truly, to your point, Warren, a compromised system in a multifocal lens because we're splitting light.
Right.
And I often explain that to patients too, that we're splitting light, but the advantage is you get this range of vision in both eyes. Then I'm very picky about who I offer that to. And it's not just thinking about the mistake I think we often make is we try to optimize everything for the moment we're going to put that lens in, and we don't think about the lifetime of the patient. And I really spend a lot of time looking for early signs of progressive disease or dry eye that I think might either worsen or be not manageable. Because it's not enough to treat the ocular surface enough to get good measurements and think that's going to keep good quality of vision for the lifetime of the patient. If it's something that really was tough for you to get good measurements, no patient is going to be able, with the tools we have currently, maintain that ocular surface when we're going to make it worse by cutting through some of the corneal nerves, at least temporarily after surgery. So I do use it very successfully and lots of patients, but they are special patients. And I think sometimes we see patients that had multifocal technology that are unhappy because they maybe were put in the wrong patient to begin with.
And are we talking about cataract patients or refractive lens exchange patients or both?
Anybody
I mean-
that has the procedure.
Yeah,
Yeah.
I think it's either. And we
So-
really do cataract surgery even in such younger patients now than ever before. Patients right at the beginning of being symptomatic rather than waiting till they have a bigger aha, wow, things are so much better
And I
moment.
think more people are having refractive lens exchanges. But to Kathy's point, one of the problems that we see for multifocal lens patients is they're not screened appropriately. So they don't
Yeah.
they don't have topography, if I can't even imagine that, or they don't have an aberration profile. If somebody comes in with 0.4 microns of vertical or horizontal coma and they get a multifocal lens, they're not going to be your happiest patients. And now
Yeah.
the problem is you own that as the surgeon, and now you have to fix that. And you know, it's always, and the unhappy patient is the 6 C's that our friend Eric Donenfeld always talks about: cornea, coma, centration, capsular fibrosis, CME, and crazy.
One question. Recently, we had a big discussion with in a panel about preoperative assessment of phorias, like in strip, like how do you say it in English? Phoria.
Euphoria.
Monofixations
Phoria.
or phoria that become atropia later on.
Yes, or that will make the patient more symptomatic after surgery with like not being able to fuse the image. Do you test it? Like, I understood you have total different scenarios, which is great for presbyopia treatment. Do you regularly test your patients for that preoperatively, or you just ask the patient and assess very quickly if he has a strabismus actually, but like not phoria? How do you do that? Or you ignore it and hopefully
for
he
the
doesn't
best.
have it?
Well, if a patient has a history of aphoria that's
No.
only intermittently symptomatic, oftentimes they'll tell you that. But when you check the pupil for an afferent defect, if they have a small trophy, it's going to show up. And then you can just go right to a 4-prism base out test or something like that. But just even checking the pupil,
Okay,
if you break
like doing the
binocularity,
cover
it's gonna-
test.
even if they have just a flick, like 2 or 4 diopters,
Yeah.
it's going to show up.
And in the case of a cataract where their visual acuity is reduced, their phoria actually may be more manifest than it will be after you've improved
That's
their
true.
vision.
That's
So-
true.
But if we see anything at all, yeah, I talk to them about that. Say there's a good, there is a chance, even if not immediately post-operatively, but sometime in your lifetime, that you'll be wearing glasses for, for a prism.
And one of the other points of conversation, because when you're doing something special for somebody, I mean, it does take a lot of time. There's no question about it, especially with a multifocal lens. So what we start off with is we say, Mrs. Jones, this is the one time in your life you're going to be able to do something like this. You
Yeah.
don't get a second chance. So let's get into this. And then they're very willing participants. It's not something casual. It's not like buying a shirt or a dress.
That's true.
You're here and we're doing some really important stuff, once in a lifetime stuff.
Yeah.
Let's go ahead and make sure we cover it. They say, Doctor, I'm so grateful.
Yeah, that's true.
And I actually walk through all the scans. Like I even do each slice of their macula. I walk them through everything in detail. As I'm looking at it, I would have to look at it anyway. So I might as well be educating the patient at the same time. So we very carefully look at all the details. Say, no, I've looked at all these things because they impact our
Yeah.
decisions and they impact your success.
Yes.
So what I do in my diagnostic room, if it measures the eye and has an on switch, I've got 2 of them.
Yes.
So
Don't need one in my mission with you.
I just might. Okay, so anyhow, like on our topographer, we have an Atlas 9000. We have it hooked up to a huge LED screen. Sit the patient in front of them, and I go through their aberration profile. Mrs. Jones, you've had LASIK. This is what things look like at night. 6 millimeter people. I take away the chroma, I add the chroma. You can add and subtract aberrations, and it becomes obvious to the patient if they're a candidate or if they're not a candidate. Or you can work with the second order aberrations. Say if you're doing a toric IOL,
Yeah.
take out the first order astigmatism. This is what's like with the toric IOL. This is
Yes.
and it's a wonderful teaching tool. If you show them before surgery, it's not your fault.
It's their
That's
problem.
true.
Yeah.
Yeah.
So again, we see people for other physicians from all over the country, as I'm sure you do, Kathy. And so somebody gets sent to us for lens calculations after refractive surgery. The other surgeon will do the surgery. We send them back, but we say this is exactly how you're going to see after surgery. And now the other surgeon gets absolution, like from a Catholic priest. You basically have shown the patient how they're going to see. They see their vision isn't going to be perfect, and they know what to expect. So we're big believers in image simulation to show patients how they're missing.
Is that hard though when sometimes patients actually do have a visually significant cataract, so nothing looks good to them even in the simulator when they have a cataract?
Well, if they're counting fingers vision, they're not going to be able to see it.
But
the topographer just works for the cornea, as though the cataract wasn't there. It's not like the eye trace or something. So this is the
Yeah,
topographer.
yeah.
So it's just dealing with the cornea and just with the first, second, third, and fourth order aberrations of the anterior cornea only.
Yeah. Yeah.
And
Because
now
we do
is-
have the eye trace, and I find the eye trace
It
is
overstates
helpful.
things.
Yeah,
It
it's
really
helpful
overstates.
Okay.
still because they still get the, and especially looking for small aperture,
Well,
improvement.
remember though too, you need to do the aberration profile at 6 millimeters, because all the aberrations are radius dependent, and if you bring down the radius, it understates things and it's not correct information. So we all have to be working from the same reference.
That's true. And to know your device, right? So like if you're used to the eye trace or if you're used to OPD scan or the Atlas, it's different to make decisions.
Each one has a different specific.
Yeah. What you value as information, and you get the tricks.
Well, the trick is to put it in a format the patient can understand.
Yeah.
Yeah, and we should, as physicians, getting people ready for surgery, we should be able to explain this to a 10-year-old child. And if we can't, then we need to learn more.
And I think that's part of like the art of how you, because you were talking about before how, really just in the conversation you have with patients, you get an idea of also their psychology and like what's a good choice that way. And I think that's like a little bit of an art that people don't necessarily understand how to approach just the conversation with the patient to sort of try to understand their psychology better in a very short interval.
And sometimes they're very anxious and they're very scared. So you start the conversation off differently. I know you're a little anxious. You know what? We're here together, and we're going to do this together, you and I, and we're going to work through all this. And you can see their anxiety just kind of melt
Yeah.
away because they know you're not just there to talk to them. You're there
Yes.
to work with them. And that's such an important thing.
I
Yeah.
often tell them, you're the boss of your eyeballs.
Yeah.
I'm not going to do anything that we
Yeah.
don't decide to do together. And I think that's oftentimes
But,
A
Another
big
doctor
Interesting.
told me I
Yeah.
had to have surgery.
Yeah. Yeah. I think a big pearl is that you mentioned that the patient needs to understand it's a decision, the lens, or I don't know, with whom to operate. It's a once in a lifetime decision because most of the times they don't think about it and it's as if, oh, I want the simplest lens. And I'm like, okay, let me explain to you the possibilities and the differences because you're going to pick.
and there's not
and
a
later
perfect
you're
a
not.
perfect solution for
No
everyone.
perfect
right?
solution, you have to understand.
It's a
And once you pick,
series of
it's a
compromises
one-way.
that you have to figure out which one's
But I
best.
think the flip side of that is sometimes patients do get the weight of the decision and then they're like, oh my gosh, I don't want to make the wrong decision. So
Yeah.
oftentimes in that
Yeah.
situation, the thing I think is helpful is I just tell the patients, I'm not going to give you a choice that's a bad decision.
Yeah.
If I'm presenting it as a
Yes.
choice, it's because it is a good decision
Yes.
for you.
yes,
The other
Good
aspect of
point.
that is patients come to us for our advice. And a big mistake people can make is give them 6 choices.
Yes.
And they will have
Yeah.
no idea what to do. So
Yeah.
we say, Mrs. Jones, in your case, if you want the best on native vision, really a toric IOL is for you. They say, oh, thank you so much. We don't give them 6 choices.
yes,
And then I think the other thing is if they're not a candidate for something they may have thought they wanted,
Yes.
tell them why.
Yep.
Because it's
Yeah.
common that I'll see that they called back. They wanted only to talk to my coordinator and they wanted to say, no, I really wanted this multifocal lens, for
Right.
instance, and a patient was not a candidate. And if it's not well documented in your paperwork, that can be where you're going, well,
Yeah.
why didn't I offer it?
Yeah.
There may have been a whole myriad of reasons, and you want to make sure that that's all
And it's
very, very
obviously
well documented.
because it's not that you did not remember that possibility, right? It's
Right.
because you thought that.
There was a
And you
reason.
can even
that
take
it
that
was
one
reason.
step further like we do, and I can show them why.
Yes.
Yeah.
With image simulation.
Yeah.
So you show them a big blurry image after 8 diopters of myopic LASIK, and
Yeah.
we say, well, that's particular multifocal lens we're talking about purchases the 2 focal points in the currency of contrast. Look how poor the contrast is. And I explained to them that the human visual system is a contrast detection system, and our impression of image fidelity, of the quality of an image, has to do with the preservation of contrast.
yeah, yeah.
So I show them,
Not
so
so
I
much
uncheck
focus.
all the aberrations. They see the letter E with perfectly straight lines. Then I start adding the aberrations back individually. Things get
Oh,
blurrier,
interesting.
blurrier, blurrier,
Yeah.
blurrier.
And
And
less-
say,
less
now
contrast.
let's make something blurry on top of that. And then they say, time out, I don't think
Yeah.
they have that. So
Yeah.
none of these concepts are difficult. They're just unfamiliar to the patients. And there's a huge difference between difficult and unfamiliar. Explaining somebody the Zernike polynomials, that's difficult.
And
explaining to them what they look like, that's easy. And it's just unfamiliar. And if you make something familiar, or you tie it to something familiar, they get it, and now you're partners again. It's all about a partnership.
I love that.
and is the simulation done with the topographer you were saying?
Almost all the topographers have image simulation. Most
Right.
people don't use it.
Right.
I've never used it. I'm gonna go back and play.
Yeah.
Come spend a day with me.
We'll invite all of them.
then
Yes.
Right? Let's all
Go
go.
steal your extra equipment and take
Yeah.
It'll be yours.
Warren, switching subjects here. You are receiving the Kelman the Kelman Awards. Is that right?
Yeah, I'm doing the Kelman lecture.
The Kelman lecture. This meeting. Congratulations for
Thank
that.
you so much. Yeah.
And you've dedicated a lot of your life to IOL power calculation and developing new techniques and new formulae and new methods of calculating IOL. How do you see our current state, and what do you see further out? How can we get better at this?
Sure.
Or should
Well,
we get better? Or is it?
Oh boy, there's always room for improvement. Just ask my wife. You know, she'll tell you. So basically, every technology has a limit. Okay, and usually most of the things we use are based on something else, aren't they? So IOL calculations are based on biometry, they're based on refraction, they're based on the technology of the IOLs. So for those of us who develop lens calculation methods, what we're interested in is the highest quality data so I can give you back the highest quality outcomes. So what I'm looking for is the next generation of measurement technology. And just going back through history a little bit, when we went from ultrasonography to optical biometry, everything changed, didn't it?
Yeah.
At least for the normal range eye. I mean, the measurements were within 2/100ths of a millimeter. I mean, my goodness, what was the sloppiest part of the whole process now became the very best. And so that part got solved, but we still have problems with the cornea, don't we? Because reflective keratometry is based in part on the ocular surface, you know. And so if we can find some way to get past that, then all of a sudden the measurements get better and better. One thing to keep in mind is that lens power calculations are based on a multi-part process. And not to get into a little bit of math though, but if you have, let's say we're making widgets, and the widget has to have a certain accuracy, and there are 5 parts to the making of the widget, and each of those have an accuracy. The final accuracy of the product is something called the square root of the sum of the squares, where you take the accuracy of the individual parts, you square it, add them together, and take the square root, okay, like an RMS value. Yep. The paradox of lens calculations, because it's based in a multi-part process, is if you take one part and make it perfect, it doesn't change the outcome, because everything else is based on a squared value, isn't it? So that's why some of the things like making lenses in quarter diopter steps or having this particular type of biometry, people spend a lot of money on equipment and they find their outcomes are really not all that better because all they did was change one component. So what we need to do is we need to make all the components better and then the outcomes better. So again, from the selfish point of view of somebody who develops lens calculation methods, what I need is really, really good data. And as the accuracy of my different study sites and the physicians who are kind enough to send us data gets better, then my calculation methods get better as well.
So big data, as long as it's good data.
Right, and that's another very insightful point, is that you can't overcome bad outcomes by just having lots of them. It doesn't work that way.
Yeah.
I'd rather have a smaller database that's really high quality.
Yes.
And how do you get good data from a bad eye, in terms of irregular corneas or RKs or post LASIK or,
Sure.
or
So it depends on what type of calculation method you're developing. If you're developing something for unoperated virgin eyes, then those are the eyes you work with. So it's only the surgeon's best outcomes, no intraoperative complications, nothing weird with the cornea, no prior detachments, that kind of thing. So we just use the very best eyes. If you're doing something for prior refractive surgery, then you limit it to the type of refractive surgery. But the problem there is we don't have the measurement technology, do we? Because with LASIK, the corneas they're overread, you know.
So do you, because you are so plugged in a lot of companies as they're trying to solve these problems and develop new technology. Is there anything, do you have hope that we have new technology that's coming that's going to raise
do.
the bar?
Yeah,
Good.
we really
You don't have
do.
to tell us what, but we just want to have hope.
There's
Please
a-
do.
So I'm going to tell you a funny story. So one of the jokes that I sometimes tell is the problem with ophthalmology is it's full of ophthalmologists. Of course, said in the nicest of ways. So if you want to solve a problem in physics, mathematics, or optics, what you do is you talk to mathematicians, you talk to physicists, you talk to optical engineers.
Yeah.
And so the problems that we're looking to solve for lens calculations are, of course, at the end of the day, an ophthalmology problem, but the mechanism by which we solve these are based in physics and mathematics.
Oh.
And so I have a network of friends that are mathematicians and physicists, and we work together on things. So that's where a lot of the answers come from. Is they come from
Yeah.
people actually outside of ophthalmology
Uh-huh.
who work with us to solve the problems that are.
And you all know that Warren is first a physicist, so that's why he's.
No, we didn't get to that part.
That one I
Wow.
didn't know. Yeah, I know,
We
right?
just like to have
That's
fun
amazing.
with numbers. But so one of the tricks of doing lens calculations is knowing who to talk to.
Yeah.
So when we worked on the RBF method, I worked with very, very well-known PhD mathematicians who work in artificial intelligence.
How did it all start? Like your idea for a formula, because it was the first formula based on artificial intelligence,
Yeah,
right?
it was the very first one.
How did you come up with the story, the idea?
Well, frustration. So if
Mother of many
Right,
inventions.
I know.
yeah. So basically, if you look at the limitations of a Gaussian theoretical formula, it's the effective lens position, isn't it?
Uh-huh.
And it can only be estimated, it can't be calculated. So a lot of people think, well, the ELP is this. No, the ELP we think is this. So we needed to look towards something that had no ELP. So pattern recognition is one way to do that. And so in the early forms of artificial intelligence, which is what we were working with, worked purely on pattern recognition.
Oh.
The same pattern recognition that allows you to get good mileage in a car. In certain cars, there's a little black box, and in that black box, there's a little chip called a prom, and that prom controls spark plug timing. And some of the same algorithms that are used for spark plug timing are also used in some of the work that I do. It's pattern recognition. And one of the great things about mathematics is there are very few original ideas, but what there are is original applications. So we take existing ideas
Yeah.
and we apply them differently.
Uh-huh.
So when you say, I'm so sorry.
No, go ahead.
When you say pattern recognition, is it because you're looking at combinations of data and outcomes and you're matching those and then you're saying this pattern of input, this combination of data for the geometry of this eye will have this outcome?
It's,
then you're
it's actually
linking
simpler
those.
than that. So in a straight neural network, we start out with a whole bunch of data. We start out with Doug Koch and Lee Wang, and I started out with 13 different measurements. We left out the patient's zodiac sign, shoe size, mother's maiden name, and favorite dessert, but we got pretty much everything else. And then we did a Darwinian reduction. So it's kind of like survival of the fittest. You make a basic formula, a basic construction, and then you do lots of iterations with scary fast computers. You generate what are called candidate models, and then you change a few things and do it again and again and again until you don't get any more accuracy. And what we found was axial length central keratometry, ACD, and the IOL power that was implanted were the four most important things. So then we built artificial intelligence models based on those. Okay. Now the patterns we look for is an axial length of 23, Ks of 44, ACD of 3.25, and an IOL power of 20. That's a pattern. And
Uh-huh.
if you have a large enough database, you can generate models. And then the way it works is you take this basic model and you do something called a backward propagation method, where you run data back and forth through these models and train them so the outcome can predict.
What all the input
But
data
you
would
don't want it to be exact. That's called overfitting the data. So,
Oh.
so the way in which different mathematical functions are assigned to the data as it passes through the artificial intelligence is something called an activation function. That's kind of what gives the mathematical personality to an artificial intelligence model. And the activation function that we used looked at the data in a radial method, kind of like the hands of a clock. And that activation function is called a radial basis function. That's where RBF came from.
RBF.
Yeah.
So,
There we have it.
Yeah.
so as we get more sophisticated, we can use multiple activation functions. We can have many, many different layers to the thing. And then the next version that we're using is going to be using a completely different artificial intelligence model. And we're starting from scratch. We're
Wow.
starting over again with different biometry, more sophisticated biometry.
I must say that did not sound very simple. You're saying that was simple.
So much simpler.
Yeah, I know. But listen, how good can we get? I mean, what do you see in the future are limits? Because there should be a limit that beyond which we will hit a wall, right? Or isn't there?
You know, before you answer that, just a thought. This morning, Renato answered that, and he said, we are always, as an ophthalmologist and surgeon, refractive or cataract refractive, searching for perfection. And perfection is something you're never getting there. But at the same time, once you're trying perfection, and then you get better, and then you see it's further out. So but we improve.
Well, whoever thought that.
But it seems that every improvement gets a bit smaller, right? Because it's kind of a hyperbole
Well,
curve.
it's because of it's a square root of
Yeah.
seven
Yeah,
squares.
exactly.
So, well, whoever thought that? Okay, if you look at interferometry, okay, this is going to blow your mind. Interferometry is from 1881. This is not modern technology. Albert Michelson won the Nobel Prize for it before the First World War. Okay.
Oh my
This
goodness.
is old technology, and it used to be used to measure the diameter of stars. That's a little bit bigger than the axial length of the eye, don't you think?
Just a little bit.
Yeah. So
Wow.
again, a man named Fercho in Germany decided, he worked for Zeiss, let's take this basic Michelson interferometer, that little blue cube that you used in physics class, and let's use it for the eye. And that's how the IOMaster started. Again,
Wow.
an original application of existing technology. So to answer your question, yes, we're already at a limit right now because we're still using reflective keratometry. It's still better than OCT. Reflective keratometry is from 1859. It's kind of old stuff, but it still works very well.
Yeah.
What I think we need to conquer are two things. We need to conquer the cornea, okay, because that creates a lot of mathematical noise. And the other thing is the refraction. The refraction is the noisiest part of what I do.
It's where the outcomes come from.
And
Yeah.
isn't it the whole point?
Yeah.
We should spend more time on that.
Yes. Yeah.
So, but I mean, if in a perfect world,
Sure.
when we had perfect input, our diagnostics are perfect, our formula is perfect, we're going to be limited by how our lenses are made and the tolerance in lens powers, correct?
Well, the good news is that the major companies have incredible tolerance. Now, you're referring to the ISO standards.
Yes.
Okay, so like the 21 diopters, it can be like that. That's not how the lenses are made, though. So a lens, like the premium lenses from one of the big companies, they're within a tenth of a diopter, but they're in half diopter steps.
Right. You can't get them that way. That's
Yeah.
really what I'm talking about is how they're manufactured as
Well,
well.
they're manufactured with incredible tolerance. It's 0.1 diopter
Right.
typically, but
But you can't
but-
get a customized power for your particular
that is
needs.
off-the-shelf
Yeah.
technology. You can do a custom pinball, but there's no real market for it. But again, if you go from half diopter steps to quarter diopter steps, because of the mathematical noise of the other parts, you're not going to see
It
it.
wouldn't matter.
And that's why industry hasn't done that. Also,
Oh,
it's an inventory nightmare, isn't it?
Yeah.
Yes.
Oh, I imagine.
You're
It will
doubling the
double.
inventory.
3D
Yeah.
print perfect
Yeah.
lenses for patients.
for
at the time of
imperfect
their surgery.
Well,
patients.
even if you could make a lens, 21.03752 diopters, the calculation method to get to that power is still imperfect. So
No, that's what I mean. Once we get the diagnostics and the formula perfect, then we worry about 3D printing.
And then there's still the surgery,
Oh,
right?
that.
There are speaking, I mean,
And then the
but there's a small
healing and-
detail that the surgery is not,
And it's
it's
a
not
different
specifically.
But actually, you bring up a good point. The surgery is close
Key.
to perfect. If you look at all your cases, I mean, you have 360 degrees of capsule overlap. You're making a beautiful incision. I mean, the lens isn't sitting in the middle of the vitreous. you know?
No.
Yeah.
I mean,
Yeah.
our surgeries they're fine.
Technically very
Which is
good,
a
right?
good point too, that healing is different for patients as well, and capsular contraction is different for patients. And so there are some things, even with perfect surgery,
Yeah.
perfect diagnostics, and perfect formula, perfect IOL production.
Yesterday we were just talking about that, like cornea, how the incision will induce if you're a younger patient, an older patient, right? And
because
how
of
it changes.
corneal rigidity.
Yeah.
And then there's the light adjustable lens.
I think that's a way maybe to solve all these. We will
Our
improve in
limitations,
the
yeah.
planning and the surgery, but there's still the tricky parts
So
with
the light adjustable lens bypasses the physical model.
yeah.
So, we may be left with some variance,
Mm-hmm.
okay? And then we can make up for that after the fact. So right now, that's where technology is driving us.
So
But
the limitation is, though, we're solving for that moment. And people change, their geometry changes over the course of their lives.
truer words have never been spoken.
And do you think the light adjustable lens is another example of old technology with a new application? Because it's not a new concept, right? How long has been the light adjustable lens
They started in
around?
like 2004. So
Oh, when I was a resident, which was before then, was working on it then. So excited about the material. Back in the suit. So yeah, in the 90s.
my goodness.
And-
So if you
and-
can't fix it beforehand, fix it afterwards. What did the carpenter say?
Yeah.
Hammer to fit and paint to match?
Yeah. But at the same time, you were pointing out how this should not make us less focused on perfection in planning. So you have to plan all the details to get the best outcome possible. If you do have a little outlier, you can titrate with the adjustable.
And to that point, another reason why the light
Technology.
adjustable lens is so accurate is my partner Yuri McKee always likes to talk about his training in the military. In the military, when you're trained to shoot a gun, what they tell you is aim small, miss small. So
Perfect.
for the light adjustable lens, we still do the very best calculations.
Perfect.
So our adjustments are very small. And in that way, you're that much closer to perfection. But the surgery that everyone's doing right now, it's very predictable, isn't it? I mean,
Yeah.
that part's really, really
Yes.
good.
Unless I want to switch gears here because I know how busy you guys are, and I don't want to take this too long. You were saying the surgery is perfect unless it is not, and sometimes it is not, and you end up with a disastrous situation of an aphakic eye, which is a point that you had a talk on that, on how to fix these complex eyes and how to fixate an IOL in these complex eyes. There's so many different techniques at the moment. What's your current strategy, Kathy?
Yeah, so there are so many different possibilities. Once things go awry, once they're not perfect, the solutions become many, right? And just depends on the individual situation of the patient. But I think the more common things, which are things like zonulopathy, those, we have good ways of fixing those and keeping as much of the anatomy as possible. So my strategy is always to try to keep the bag and try to stabilize the bag. And then the rest of the surgery is predictable and has predictable outcomes. So some of the things we have now, using capsular retention segments, using polypropylene suture to do that in an appropriate way, have really helped to allow those patients who in the past would have been somebody who needed a vitrectomy and, either an anterior chamber lens, heaven forbid, or a scleral fixated lens another way. Now we can really have a normal surgery once the bag is fixated. So that would be my first approach, is always try to save the bag.
Right.
Sometimes you can't, and unfortunately, although Yamani's been a great addition to our armamentarium, using the CT Lucia lens has resulted sometimes in these rotisserie rotations, which makes it a little bit more challenging. So we're always looking for another way to do that, either with a different lens, which there are alternatives, maybe the haptics aren't quite as robust, or different suturing techniques. And I've been working with some companies in ways of maybe simplifying that. You're lucky in Brazil because don't you have the artisan lens? You can use an aphakic powers.
We do.
So we don't have that.
We do, but we don't have the CT Lucia lens. So it's a trade-off.
Yes, it's always a trade-off. It's
Yeah.
always a trade-off.
Yeah,
But it's
so-
interesting we went from presbyopia correcting to a phakic correction. It's like
Yeah, to very, very different
An important topic.
treatment of modalities. Right?
Yeah.
And then one thing we make sure that our patients understand is there's a difference between refractive and rehabilitative.
yes.
So if you have a single
Yes.
chamber eye,
Yes.
that's had a very difficult path. and you're doing a Yamani fixation, that's a rehabilitator.
Perfect.
And then,
Yes.
so our goals are just a little bit different.
Yeah.
And I found that using, lately, what I've been doing is more of a hydrophobic acrylic platform, like neutral asphericity, so it has similar tolerance to decentration
So
to
like the
tilt.
LI61AO.
So yeah, like that, or the Vista, and then using the fenestrations as a way of fixating in Vista lens. But that whole series of lenses gives you lots of options, 3-piece options, and then the fenestrated option as well.
And do you suture the Envista with Gore-Tex with
So Vortex
polypropylene?
works, but lately I've been using more like 7.0 or 6.0 polypropylene suture.
Oh, nice.
It's a little more flexible.
Right.
5.0 is not flexible enough, actually. So 6.0 and 7.0 work well to keep enough flexibility that you're not distorting or torquing.
Right. And for pseudosfoliation patients, you were mentioning that you always strive to preserve the bag. And do you think that the bag, even if you get to preserve it, it's the best place for the lens to be? Or is there a place for implanting the lens in the sulcus and up to capturing the IOL? Or
Yeah, that's a great question because I also do a lot of global ophthalmology, and we don't always have all the resources that are available at my home OR. And generalized zonulopathy, a really great solution for that is to put a CTR in the bag and put a 3-piece lens in the sulcus and do optic capture. Optic capture keeps the whole bag complex stable and not falling posteriorly or decentering, and the lens is very stable as well. And in those cases, which I've had to do those, frequently enough in complex situations outside the country, I'm really looking at the bag more as a place to keep the vitreous back so that we don't actually have to do a vitrectomy. Because anything you do that's more complex in those settings, where there might be a secondary complication and maybe the tools or the expertise are not going to be available in weeks or months later, you really want to try to leave the most stable situation possible. But it works well even anywhere. I use that for patients when I have generalized zonulopathy, like a pseudoexfoliation.
So in the Caribbean, this would be traumatic rather than genetic, because I don't think there are a lot of Norwegians in the Caribbean.
Well, there probably are some, but yes, you're right. When my mission is in St. Vincent, we don't often have a pseudo-exfoliation. I mean, we do sometimes. There is a population as well, but it's not as common as I see it.
Yeah, and if you see zonulopathy during surgery, watch the pressure afterwards, because sometimes these people get these pressure spikes.
Oh, good tip. Yeah. Yeah.
And managing these discentrations later on, do you think that the CTR may be helpful in these patients, or does it prevent any discentration at all, or how
There's
does
some
it work?
data
Yeah.
that shows yes, maybe yes, maybe no. If you have a pseudoexfoliation patient with no evidence of zonulopathy, there's no data to show that over time it really helps. But if there's already evidence of zonulopathy, then the long-term data looks better. But I do put it in not necessarily just for that, but because if I have to go back in and refixate it, it just gives me more property, more
Yes.
potential candidates for suturing in a refixation setting, which we do have a lot of I get a lot of dislocated. You get all the unhappy multifocal patients. I get the dislocated IOLs.
They're also
And so I do try to preserve the bag and the lens in those cases and avoid a vitrectomy. Again, just trying to avoid more complications. And if there's already CTR in there, it just gives me a lot more real estate for suture.
That's true.
Well, I think we've had so many good pearls, such a great time to here. I want to thank you so much for stopping by, for having this chat, for coming to Brazil and giving all the talks I know you guys are giving. Bruna, thank you again for being a co-host here with me.
My pleasure.
It was great to have you guys here. And I look forward to seeing you in the next lectures that you are about to give. Thank you so much.
And in next
Lauren.
Brascrs also, we're already planning
Exactly.
for next year.
Yeah,
Well,
exactly.
a total absolute pleasure being here with all of you. A great honor to be here.
The same with you,
Lauren.
Kathy. It's been a wonderful meeting so far.
Yeah, thank you so much.
Thank you. Great having you guys here. Thanks.
Thank you. Thank you.
Thank you.
Wonderful. Oh, yes.